Hello, Dr. Darty here. Today we're going to be talking about breathing, which in your book is chapter 8. A lot to talk about here, but before we get started, here is one for you trivia buffs. What do you think is the world record currently for holding one's breath underwater? I'll give you a minute to think about that. Cue the Jeopardy theme. The answer is, ready, 24 minutes and 33 seconds. You can read all about the sport of breath holding. It's an offshoot of free diving, sort of like one of those odd sports like hot dog eating or, I don't know, something that rock, paper, scissors contest maybe. Anyway, there are people who stake their fame and fortune on how long they can hold their breath. And you can see interviews about it if you Google it. Today, we're going to be talking about my favorite system, I guess. I don't know, I like them all, but I'm partial to the respiratory system. It is so elegant, so beautiful, and obviously is critically important to keeping us alive. The main purpose of the respiratory system is to deliver oxygen to your bloodstream, which can be carried by those magical red cells to all the parts of your body that need it. You might think, why do we even need oxygen? Well, if you take a class in biochemistry or a more involved physiology course, you will learn that what those little oxygen molecules do is at the very end of cellular respiration, when your food is being turned into ATP, the magical chemical that makes you go, they catch the worn out, spent electrons at the very end of the electron transport chain. And that allows your body to turn some of those electrons and the oxygen into water. You make about 10% of the water that your body needs every day yourself. It's a pretty cool system. The other function, one of the other functions, is to get rid of the carbon dioxide that your body generates as part of that process of turning your food into energy. And that has to be gotten rid of. The respiratory system gamely tackles both challenges. It also plays an important role in immunity because in those little air sacs, the alveoli in your lungs, literally the outside of you, the air that you breathed in, comes perilously close to your bloodstream. Otherwise, the oxygen couldn't diffuse in and the carbon dioxide couldn't get out. So it's a very vulnerable place for your body, as is your skin and your digestive tract. It's a place where the outside of you and the inside of you come very close together. So there are a lot of immune functions, if you will, sort of barriers to bringing bad things into your body that are part of the respiratory system. Your respiratory system, in doing all that stuff I just talked about, also helps to balance your pH, the acid-base balance in your blood. In fact, it does it very, very quickly. You have chemical buffers in your blood that act instantaneously, faster than you can really think about. But in a matter of seconds, when you start to have too much acid in your blood, maybe you were running up a flight of stairs, or maybe you tried to hold your breath for 24 minutes and 33 seconds. When you start to build up acid in your blood, causing the pH to drop, you'll learn more about that at some point, then your respiratory system immediately tells you to breathe faster. Because in getting rid of that carbon dioxide, you also help to raise your blood's pH back to its very narrow range that allows you to stay alive. I think your book, obviously your voice is the structures that allow you to speak are housed within your respiratory tract as well. And in the top of your nose, you have those magical cells that allow you to smell, the sense of olfaction. So we have a lot of things going on in the respiratory tract. The main thing is to get oxygen in and get carbon dioxide out without getting bad guys in that could harm us. We've learned a lot about that during COVID, haven't we? All right, so let's try to get a grip on this. The respiratory system has really two main components. Now, your book, and for those of you taking physiology, this is a little bit of a caveat. Your book says right at the beginning, I'm looking at it, the respiration has ventilation and exchange of gases. Well, in the physiology books, they break that down and say ventilation is the physical moving of air in and out of the respiratory tract, whereas respiration is that magical exchange of carbon dioxide and oxygen down in the little tiny alveoli of the lungs. So just if you're going on to A&P or you've already had A&P, somewhere along the line, the definition might be a little different. I find it useful to think of the parts of the system, and that's most of it that you're aware of, that allow the air in and out, and then the little alveolar sacs in the lungs that allow gas exchange. You might think of it a little bit, it's a crude example, like an HVAC system that somewhere outside your house or in your attic, there is a machine, and we're glad in the summer, that cools the air, that does the real business of the system. But there's a lot of duct work and piping that allows you to experience that lovely coolness, or if you're watching this in the winter, the warmth that comes from your HVAC system. So most of what you are aware of or think of as your respiratory system is really ductwork, vents. Starts two places at the top. You have a nose that has two, we commonly say nostrils. The medical term for each one of those is a naris, N-A-R-I-S. We hardly ever say the singular, although pediatricians sometimes do when a kid puts something up there they shouldn't. But usually it's nares, plural. So for instance, if I was seeing a child with what we call a snotty nose, I would dictate into my dictaphone, child presents with mucopurulent discharge from both nares. We say that instead of nostrils. Those nares are divided by a septum, meaning a wall, and you may have yourself, or I'm sure you know someone who's had a deviated nasal septum, one that is crooked and may cause some trouble with them breathing through their nose. It's a pretty common problem, especially in people whose noses have been broken. In the top of your nose, as we mentioned, are the top of your nasal cavity are the cells that allow you to smell, and they have a pretty direct nervous channel right into your brain. That's why when you smell something from your past, you think about how your grandma's Thanksgiving dinner smelled or the cologne your old girlfriend wore. You might think, right away you feel that emotion because those nerve endings go right into the part of your brain that are intensely busy with memory and emotion. There's a whole perfume industry around that, you're probably aware. All right, then behind your nose, you have the nasopharynx. That's the part of your throat that is literally behind your nose. Your adenoids reside up there, part of your lymphatic system, and that's one of the structures that helps to trap germs as they try to get in. If something bigger had tried to get in through your nose, like for you runners out there, a gnat, or you're running on a dusty road, you have little nose hairs. The term for those is vibrissae. We even have a fancy name for nose hairs. But moving on down, air can also come in through your mouth, and that's your oral cavity. You probably know a good bit about that. We'll talk more about it next time when we discuss teeth and tongue and salivary glands. Behind your mouth is what we call the oropharynx, meaning the part of your throat that's right behind your mouth. The last part of your pharynx is called the laryngopharynx or laryngopharynx. That brings up a point I meant to address earlier. Some words associated with the respiratory tract have different pronunciations depending on who's saying it. And the larynx in its associated terms is one of those. Some people say, for instance, for the instrument that you use when you're intubating someone and need to visualize their larynx, they call that a laryngoscope. Other people say laryngoscope. The procedure would be called a laryngoscopy if you use a hard G, or laryngoscopy if you use a soft G sound. No one that I know of says laryngitis. You say laryngitis. So a little bit of a disconnect there between our hard G's and soft G's. But it's really one of those pajama, tomato kind of things. You will hear educated speakers and speakers in healthcare say it both ways. So if someone asks you to hand them in a crisis a laryngoscope, you don't need to correct them and say, actually, it's laryngoscope, or vice versa. All right, our larynx is where our voice box resides. There's a very nice picture in your book of what vocal cords look like when visualized through a laryngoscope. For those of you who are EMT bound, and I know there's several of you in the class, there's a really important thing to know. We say if you didn't see the cords when you intubated someone, you don't really know where you put the tube. So an important landmark and very useful for talking, like I'm talking to you now. Let's see. Moving on down, we have the trachea or windpipe. At the top of the trachea, there is a little trap door that when you swallow pizza or cheeseburger closes off the top of your trachea. It's called the epiglottis. It's known as the guardian of the airway. If someone's ever told you a funny joke and you got something down the wrong pipe, what has happened is that epiglottis, as you chuckled at their funny, didn't close tightly, and maybe you got a little water or Coke or whatever down into your trachea, and you cough around for a few minutes, because nothing but air should pass your epiglottis. Your trachea has cells that produce mucus, and they work like a little elevator. Little cilia push that mucus up towards your mouth so you can swallow it. You're not usually aware of that, but you swallow about a quart of mucus a day. Isn't that a lovely thought? But trapped in there is all kinds of things you don't want to get all the way down in your lungs that can make you sick. And that's why when you do have a respiratory tract infection, you make more mucus, because it's like, let's get that out of here. So your trachea. The trachea divides in your chest in the mediastinal area. Remember, the mediastinum is the place between the two lungs in your thoracic cavity. It divides into the two main bronchi. Some of you, again, with some background in this, may already be aware, but one of those is a straighter downward shot than the other. The right one tends to be more of a straight shot. So if someone aspirates like a button, or if you push your endotracheal tube in too far, it tends to go into the right main bronchus rather than the left. Then once the bronchi begin to divide, the main bronchi, we call that the bronchial tree. There's a nice picture in your book, and it looks like the branches of a tree or the roots of a tree, because each airway divides many times until we have really tiny little bronchi that have the cute name of bronchiole. The bronchioles are the last little part of your airway before you enter the air exchange sacs called alveoli. Those bronchioles, the last little bit of them, have smooth muscle around them. And you may remember from the chapter on muscles, smooth muscles involuntary. And so those muscles can either constrict or dilate to let more or less air into the alveoli. If those little smooth muscles constrict when they shouldn't, when we wish they didn't, the person may start to wheeze because it's easier to get air in than out, and that's called asthma. So you probably are aware of that, and we use an inhaler to cause those muscles to relax and let more air be exchanged. Then the last part of the respiratory tract as we go down, the part where the action is, the really magical stuff happens, are called the alveoli, singular alveolus. And the alveoli are little tiny sac structures lined with a very thin membrane. And each of them is surrounded by a network of capillaries, tiny blood vessels. And the little bit of tissue between the blood and the alveolar sac at that point is very, very thin, whisper thin, so that oxygen can diffuse from the sac into your red blood cells, and carbon dioxide, or CO2, can diffuse out. And that's how the system works. We need a few more things that are outside the tubes themselves to make it work well. We have to change the volume in our chest to cause the air to move in or out. And again, if you take physiology, you'll learn much more about this than you probably wanted to. But basically, when you inhale, if you'll just do it, you can feel a couple of things happen. Your diaphragm moves down. If you put your hand on your belly, you can feel that your belly may even push out just a bit as the diaphragm moves down. And by the way, diaphragm is hard to spell. Don't forget the G. I have no idea why it's in there. D-I-A-P-H-R-A-G-M, diaphragm. It moves down and makes your chest cavity bigger. And at the same time, little muscles between your ribs called intercostal muscles cause your ribs to move up and forward a bit. As your chest cavity gets bigger, air flows in. Now, when you exhale, that feels, doesn't it, like a passive process? You didn't have to do anything to let your air come back out. Those muscles relax, your chest cavity gets smaller and the air is forced out. So that's what happens with every breath you take. Now, clearly, we don't want anything to go wrong with this system, but things do go wrong. And that's what a lot of the words in your chapter refer to. So I'm going to sneak a peek at my hard copy of your text here and just draw your attention to some of them that may give you trouble either with meaning or pronunciation. We hit almost everything there on that first page. A pulmonologist is a person, as a physician who specializes in diseases of the lung. I think a lot of these you already know. Oh, there's one I didn't mention. We were talking about noses. You'll see a lot of patients with nosebleeds, and the fancy word for nosebleed is epistaxis, and it's right there on page 189. Things that can go wrong. Rhinitis. Rhino is your nose. Like a rhinoplasty is a procedure a plastic surgeon does to change the shape of someone's nose. Rhinitis means an inflammation of your nose. So if you have allergic rhinitis, like hay fever, that may mean that your nose gets watery and irritated from ragweed or cat dander, whatever. When you get an upper respiratory infection, then you also could have a viral rhinitis. That's what a common cold is. Sinusitis, you live in Kentucky, you know more than you ever wanted to about that one. Now here's some other words that right now seem to be the pronunciation in flux. A few semesters back, I had one of the nursing instructors call and say, Karen, how do you say apnea? And I said, apnea. And she said, yes, that's what we always thought. But now the newer texts are saying apnea, which to me sounded very strange. Your book has as its preferred pronunciation, as does Merriam-Webster and several other sites that I looked up and listened to, apnea. And when I hear people talking about sleep apnea, they tend to pronounce it that way. But just be aware that there are some folks out there who are making a play to say it apnea. Sounds strange to me. Now, if we are breathing too fast because we've been running or we're having a panic attack or whatever, the word for that, as I learned it, and that's featured in a slightly later table in your book, is tachypnea. Tachy means fast, like tachycardia is a fast heart rate. Tachypnea is breathing fast. But your book there switches over to the new way of saying it and says the pronunciation is tachypnea. I don't know that I can get myself to say that consistently, but just be aware that those two words and the word that means breathing slowly, which you don't hear as often, is bradypnea, or as I learned it, bradypnea. So the emphasis on which syllable is accented. Again, different speakers may say it differently. The word for breathing normally is eupnea, E-U-P-N-E-A. Again, I checked it out on several medical sources and they used eupnea, but some people use eupnea. See, I can't even say it, eupnea. So I don't know. But the one you'll hear most often is apnea. If you go into especially neonatal ICU, babies are prone to what we call A and B spells. And what that stands for is apnea and bradycardia. Because they're little preemies, they literally forget to breathe and their heart rate falls. And we have to jiggle them or provide a stimulant medication. So usually we say apnea, but you may hear apnea. Hypoxia means exactly what you think. If you're not getting enough oxygen, then you have hypoxia or hypoxia. Just looking to see here. We talked about the epiglottis. Used to be, before we had H-flu immunizations, Haemophilus influenza immunizations for children, toddlers especially would get a very serious bacterial infection of their epiglottis called epiglottitis. It still occurs once in a while, usually now from staph germs instead. But it's very serious because if it becomes swollen enough, the epiglottis, it can block off the whole airway. So epiglottitis is mentioned in your book. Could result in the next word that's listed on page 193, intubation. Endotracheal intubation. Very prissy sounding phrase. But let's break it down. Endo means inside. Tracheal, the trachea or windpipe, intubation, putting in a tube. So when you see them on the medical shows tubing someone, they're performing endotracheal intubation. Let's see. mediastinum, and we talked about that before. I didn't mention that the lungs are different physically in a couple of ways. Your right lung is somewhat bigger, and it has 3 different lobes divided by 2 fissures or ditches, I guess you'd say, seams between them. The left lung is sort of has to give a little room to your heart, which pushes slightly to the left, and it has only 2 lobes, an upper and a lower lobe, and just 1 fissure. But if you hear that. The membrane, and I think we mentioned this before, over the outside of the lungs that helps them, separates them from the chest wall, is called the pleura, P-L-E-U-R-A. Don't spell it like plural in an English class. It has an E-U-R-A. So that can become inflamed, and that's what we call pleurisy. It's very uncomfortable. Or someone can have a pleural effusion, where pus or blood or fluid accumulates in that space and keeps the lung from expanding as fully as it should. And that obviously is a serious situation. If there's enough fluid in there, the patient may need to have a thoracentesis. That's where we actually insert a needle and withdraw some of the fluid. We're getting most of them. Oh, I didn't mention this. I said apnea and eupnea and all those. I didn't mention dyspnea, D-Y-S-P-N-E-A. It's hard kind of to say dyspnea. Dyspnea is the sensation that you're having trouble breathing. So that can happen for physiologic reasons. It can also happen for emotional reasons. But dyspnea, you might think of it as air hunger. Expectorate is to spit. You probably knew that one already. Phlegm, I bet you knew that one already. Hard to spell, another one of those words with an extra G. Then there are several. Oh, here's one you hear mispronounced sometimes, rhonchi. When you do physical exams on patients, you will hear rales and rhonchi, and those are the swishy sounds in the lungs. Rhonchi are coarser, rales are higher pitched and more crackly, I guess you'd say. So those are both mentioned there too. To auscultate the chest means to listen. Auscultation will say lungs are clear to auscultation, means I listened with my stethoscope, and percussion, where we pound on your chest to see if we detect any fluid where it shouldn't be. Oh, look at all these things. Emphysema, pneumonia, pneumonitis, pneumothorax. That's one you will also encounter, unfortunately, with some frequency. That's when air gets in the space between the chest wall and the lung. And if it's significant enough, it keeps the lung from expanding. When the lung collapses, that's called atelectasis, another tongue twister. So collapsing of the lung is atelectasis. It can be a little bit or disastrously a lot. And pneumothorax means that we have air in there where it shouldn't be, between the lung and the chest wall. Those patients sometimes need a chest tube to evacuate that air. And then toward the end, we have some diagnostic procedures. A bronchoscopy means exactly what you'd think, that we look down with a bronchoscope through the trachea, and we can thread, I can't, but specialists can thread quite a way down into the respiratory tract to see what's going on, whether something needs to be removed because you aspirated a button or whatever, or if they needed to get a sample of a mass that's there to diagnose cancer or rule it out, that can be done. Spirometry is where we measure how someone is breathing, how they're exchanging air. And there are several components to that. How much air can a person exchange and how long does it take them to do it? There are multiple components to a complete spirometry evaluation, but it's sometimes recommended if we suspect someone has asthma, if someone has emphysema and we want to see if the treatment is helping or if their disease is progressing. So we call the test that we do with a spirometer pulmonary function testing. And those of you going into respiratory therapy will learn a lot more about that. I think that's enough big words for today, probably. If you have questions about any of them that you read about or that are featured in your chapter review, then certainly give me an email and I'll be happy to try and help with those. Thank you for checking in with me. Good luck.